stroke is being one of the major causes of death. It is being one of the major causes of death and disability in India. And nearly 150 persons per thousand people are being affected by this stroke, and they need immediate treatment. And this is one of the major causes of disability in India. And it being such a prevalent disease, and without proper awareness among people, a lot of people suffer and they need immediate.
Pardon?
Can I ask you my first question, sir?
Has the...
Can you tell me?
Yeah, you can ask, no problem.
So, sir, what is stroke, sir, and what is its medical definition? And when do we say that a person has stroke?
You know that, see, this is something which has been there from the years of before Christ itself. It has been described before Christ. And after Christ, the Hippocrates, he used the term apoplexy. Apoplexy, which means there is a sudden event which is happening. So the stroke is a sudden event. It happens just like a bolt from the blue, like a lightning it strike. That is why it is called a stroke. And so what is the medical definition of stroke? There's a WHO has defined stroke in a specific manner. According to WHO, the definition is of stroke is a sudden focal neurological deficit lasting more than 24 hours, confined to an area of the brain, perfused by a specific artery, and presumed to be of vascular origin. That is the actual definition of stroke. So it has to be confined to a single specific area where an artery is involved. It could be brain or the retina also, because ophthalmic artery is a branch of the internal carotid artery. And this deficit has to last for a long period. Why? Because this has to be distinguished from another entity called transient ischemic attack. The difference between a stroke and a TIA comes basically because the TIA reverses automatically without much changes in the brain, without causing much damage to the brain. It reverses, whereas a stroke causes permanent damage to the brain unless it is clearly, totally, if you don't clear the occlusion properly. Then we call a patient to having a stroke because somebody who has got suddenly he develops a focal neurological deficit. And what is this focal neurological deficit? That means a specific area of the brain is affected. For example, if your anterior circulation is affected, you get specific findings. If your posterior circulation is affected, you get another set of findings, depending on which area. For example, some person, a stroke, it may be a loss of speech. For some people, it may be a facial deviation. And for some people, it could be just a weakness of one of the limbs, like an arm drift. So, depending on the area of the brain which is affected, suppose if the posterior circulation is affected, it will present predominantly with a giddiness and vertigo. It can present with cranial nerve findings like diplopia, swallowing difficulty, and it can present with ataxia because of cerebellar involvement. So, whereas in anterior circulation, it can usually present with weakness of one side of the body, as happens in a hemiplegia, unilateral, one side arm, leg, and with face. There's a classic complete hemiplegia, which happens in an anterior circulation stroke. So, stroke is just a symptomatology of a vascular occlusion pertaining to a specific area of the brain. And why is it called stroke? Because this happens suddenly because of the vascular occlusion. And the strokes can be of two types mainly. It can be the majority of the strokes are due to vascular occlusion. I would say around 85 to 90%. Whereas 10% of the strokes are due to hemorrhage in the brain. That's called as a hemorrhagic stroke. So why this distinguishing feature? Because clinically also you can distinguish a hemorrhagic stroke from an ischemic stroke. In a hemorrhagic stroke, the patient will have more of features of a raised intracranial pressure. Whereas in acute ischemic stroke, the intracranial pressure elevation will not be much early in the earlier onset of the stroke. Later on, you can have it. So this is what the definition of stroke, and this is how you distinguish the clinical picture wise, how you distinguish a stroke.
Okay, okay, so that was a very good explanation.
Yeah.
Can I move to my second question, sir?
Yes.
Okay, so what are the leading causes of stroke, sir? And what are the more vulnerable age group people who are more prone to get this stroke? And is stroke associated with any lifestyle modifications?
Yeah. See, basically, if you at fundamental thing, what you should understand is stroke is predominantly a disease of the older age. As your age advances, every decade in life advances, your chances of getting a stroke is more. So if you most of the strokes happen in people beyond the age of 50 years. As you become 50 to 60 is the usual type when you get a stroke. But as you become 60 to the 60 to 70 age group, there is a more than 10% increase. Again, so when you become 70 to 80 age group. So as your age advances, your chance of getting a stroke is high. Because the vascular changes happen in the body, in the brain. Slowly the atherosclerotic changes happen, arteriosclerotic changes happen if it is due to hypertension. Surgeon is having diabetes, those changes happen. So all these factors compound to produce a stroke. As you become older, your chances of getting an atrial fibrillation is more, which is called the paroxysmal or a lone atrial or a persistent atrial fibrillation. All these things cause a stroke as you become older, but that doesn't mean young people don't get stroke. 25% of the strokes happen in a younger patients, less than 50 years. That worries us more because they are the most probably they are the highly energetic people who are working people who are breadwinners of the family, and that causes a lot of burden, economic burden for the family when they get affected. That does not mean that the older people, when they get, the family is not affected, but this really ruins the family. So that is the burden of stroke. And mind you, in India, every minute, three people suffer from stroke. That is the Indian statistics. Now, what are the predisposing causes of stroke? What leads a patient to have a stroke? The foremost, the forerunner of stroke is age is the most important factor. Somebody asks you, as you advance in age, your propensity to get a stroke is high. So the number one risk factor for stroke is advancing age. Then comes hypertension. Hypertension is a very, very important cause of stroke. Control of blood pressure is extremely important in preventing stroke. If you can alleviate hypertension from a society, the chances of stroke in that area will be very high. Very less, I'm sorry. Now, diabetes. Diabetes is another important cause of stroke. So the two front line runners of stroke are hypertension and diabetes. Then, of course, cigarette smoking. If you smoke the cigarettes, your chance of getting a stroke doubles. It depends on the number of cigarettes you smoke. Then excessive alcohol intake is another important cause of stroke, both ischemic stroke as well as hemorrhagic stroke. Then substance abuse increases your chance of stroke. Then sleep deprivation, sedentary lifestyle, obesity, all these increases your chance of stroke. So I'm talking about the arterial strokes. Now, in India and more than in other parts of the world, you should know about venous strokes also. So far, I've been talking about the arterial strokes. The venous strokes are also extremely common. We come across quite a lot. The venous strokes happen especially in women in the postpartum period and peripartum period because of the increased hypercoagulable state which is present in the pregnancy and puerperium. Then another thing is dehydration. Dehydration is an important cause of stroke, especially in the neonates, infants, and the elderly. How does it happen, dehydration? If they get excessive diarrhea and vomiting. Somebody gets excessive diarrhea and vomiting in the children or elderly. Immediately you have to rehydrate them. Otherwise, the blood volume decreases, hemoconcentration happens, they can go in for stroke. And majority of them develop a venous stroke. It's called a cerebral venous thrombosis, which is as risky and as dangerous as an arterial stroke. Now, obesity is a very, very important risk factor for stroke. Then another is excess cholesterol in the blood, hypercholesterolemia. Whether it is due to excess intake, or lack of exercise, or familial hypercholesterolemia. All these are important causes of stroke. Now, lifestyle I told. If you are in a sedentary habit, if you consume a lot of alcohol, you don't do your exercise properly, if you eat more of fatty food, you are likely to develop stroke. So all these things should be curtailed if you want to prevent a stroke from developing.
Okay, sir. So then, what are the physiological changes that will happen inside our body during a stroke episode?
Okay. This is a very important question, and as medical students, I think you should know what happens during a stroke. What are the physiological changes which happens during a stroke? See, if you know the physiology well, now your way of management also becomes easy. Say, what is the, first of all, you should know what is the normal cerebral blood flow. Brain is an organ which maintains its blood flow relatively constantly, irrespective of your mean arterial blood pressure. However, the pressure the heart generates, whether it is high blood pressure due to increased force of contraction, or if the heart is not pumping well, the brain tries to maintain its circulation because the brain cannot survive hypoxia and hypoglycemia. So the normal cerebral blood flow is around 50 to 60 ml per 100 grams per minute. That is a normal blood, the flow of blood to the brain, various parts, whether it is the anterior circulation or it's the anterior circulation, I mean the carotid circulation. Posterior is the vertebrobasilar circulation. Now, what happens when the blood flow drops? What is stroke? I told you that it is due to occlusion of the blood circulation to the brain, whether it is the carotid arteries or the vertebral and or the basilar arteries. So the blood flow to the brain diminishes. So when the blood flow to the brain diminishes, a stage will come when the blood flow is less than 18 ml per 100 grams per minute. At that stage, how do you find out? We do what is called the somatosensory evoked potential. That is, we stimulate the nerves in the hand or the leg and pick up the potential from the brain by using a what you call evoked potential. Evoked potential will start disappearing once the blood flow drops below 20 ml or 18 ml per 100 grams per minute. Okay, fine. Then if the blood flow drops below 12 ml per 100 grams per minute, what happens is that area of the brain is not able to survive. That area of the brain now cannot survive for more than 30 minutes. If that situation is continued for more than 30 minutes, if you are not able to reperfuse that area of the brain dies, which we call as stroke. Which we call as stroke. And if it's less than 5 ml per 100 grams per minute, even 15 minutes of ischemia, the brain cannot survive. So, cerebral blood flow between 10 ml per 100 grams per minute to 20 ml per 100 grams per minute is called the ischemic penumbra. You have to know the word called penumbra. Penumbra is the area of the brain which is hypoperfused but which is still alive. If you allow that hypoperfusion to continue for more than 3 hours, that area will die. It will undergo infarction in pathological terms. So what is your duty? You have to shift the penumbra. You have to improve the blood flow from 10 to 20 ml per 100 grams per minute to more than that. That is what we do in the stroke management. So that is fundamental as far as the physiology which happens in the brain. Then what happens in ischemia? Another physiological process. You know, any ischemia impairs the energy metabolism. So that affects the depolarization of the cells. So what does happens when the depolarization is affected? There is accumulation of calcium intracellular, and when there is hypoxia, there is lactate accumulation. Then acidosis happens intracellular. That is acidosis happens, and this leads to free radical release. So this free radical release can damage the neurons, can cause destruction of the neurons. Then activation of the NMDA. You might have heard of the NMDA, N-methyl aspartate receptors by the excess glutamate release, which happens in ischemia, causes what is called as excess excitation of the neurons and causes death of the neurons. This is the theory of excitotoxicity of neuronal death, which happens in ischemic stroke. So these are all the physiological changes. That is increased accumulation of calcium, increased excitotoxicity, increased glutamate release, lactic acidosis. All those things happens in the brain, which ultimately leads on to death if the ischemic penumbra is allowed to continue for more than 3 to 4.5 hours.
Yeah, sir. Sir, you have been telling like if the blood has been stopped for 30 minutes, it's called a stroke. So how we will be able to differentiate between stroke and a brain death? Like, is it the somewhat like how to differentiate, sir? I thought to ask you.
Differentiate between stroke and
brain death. Brain death.
Oh, brain death.
Yeah, sir.
See, brain death is a different phenomenon. Brain death
Okay.
is a different phenomenon. So you're talking of a totally different phenomenon. For brain death is a death of your brain stem. Brain stem death is brain death. Okay, for the brain stem death and the brain death to be shown, you have to show the stoppage of circulation in both your middle cerebral arteries and your basilar artery for 30 minutes simultaneously. In stroke, it doesn't happen. In stroke, it is usually one vessel which is blocked. Okay.
Okay. Okay, sir. Okay, sir. Thank you, sir. Thank you, sir.
Sir, you clearly explained the physiology of stroke, sir.
Yeah.
So what are the primary symptoms which are present in a stroke patient? And
All
in
right.
your clinic, do you elicit any signs in them? And what is the reason of having seizures in a stroke patient, sir?
All right. See, the symptoms stroke depends on which, as I told, by definition, what is stroke? It is an area of the brain which is devoid of, suddenly cut off with the blood supply. So the symptoms also depend. You know, the brain is a big area. It has got so many lobes: the frontal, the temporal, the parietal, occipital. Then there is a brainstem which has got midbrain, pons, medulla, cerebellum. So when the blood flow is cut off to each of these structures, it produces different symptoms. I will talk to you of the classical anterior circulation stroke. What happens when the middle cerebral artery is affected? When the radiculostriate branches of the middle cerebral artery is affected, what happens is patient will get capsule, the internal capsule gets infarcted, blood circulation gets cut off. He develops a deviation of angle of mouth to one side, which is called as upper motor neuron facial paralysis. He develops a weakness of one upper limb, or he can get an arm drift. Then he can get a weakness of he or she can get a weakness of the one lower limb. So this is called as hemiplegia. This is one classical symptom. You need not always get a hemiplegia. You can just get an upper motor, just a facial deviation, or you can just get an arm drift. So this is called faciobrachial type of stroke. You don't get a full-blown hemiplegia. Sometimes, on the other hand, if your speech area is affected, which is the left cerebral hemisphere, superior temporal gyrus, when the blood vessel is occluded, you get aphasia. The person is not able to speak. That will be the classical symptom with which the person will come. Then sensory inattention. If you touch both sides of the body, person will feel as if only one side is touched, or this is called as neglect. You neglect one side of the body. Then another symptom is which the posterior circulation is affected. The person can come with visual impairment. It's diplopia. The person can come with low motor neuron type of facial paralysis because the facial nucleus is affected here. Patient can come with a swallowing difficulty because the 10th nerve nucleus is affected, or the 12th nerve is affected. He gets a slurring of the speech. Then he can get ataxia. What is when the person walks, he's unsteady. He can get a giddiness. These are all the symptomatology, and he can get bilateral weakness in a posterior circulation stroke. That is almost characteristic of a posterior circulation stroke, whereas unilateral weakness happens in anterior circulation stroke. So these are the usual symptoms. These are the signs which we elicit when a patient comes to the clinic, whether there is a weakness and whether there is a what happens to your Babinski sign, plantar response. On the store, if upper motor neuron lesion, you get an upgoing plantar. Whether the person is able to talk properly. All these things are verified. The motor power is assessed. Then we come to a conclusion that, and we find out how rapid was the onset of the event. Rapidity of the onset, and with these clinical pictures, we come to a conclusion the person is suffering from a stroke.
Okay, sir. You clearly explained that concept. How and also why do we have seizures, sir, during?
Yeah, good. You reminded me that. See, seizures is usually not a feature. Seizures is, don't take seizures as a very common finding in stroke. But seizures can happen in stroke. But seizures, it need not be the one of the diagnostic criteria for stroke. But in an embolic stroke, we can get seizures because of sudden stoppage of blood flow. You get seizures in stroke. Then there's on the corollary, persons getting late onset seizures. That is, what do you mean by late onset seizures? So usually, the seizures happens starts the first or second decade of life. But somebody gets a seizures at a later onset, 40 years, 50 years. So many studies have proven that those people are more prone to develop ischemic stroke.
Okay, sir. So we have always heard a professor telling us that stroke is a neurological emergency. Yeah. And also, why is that called in that way? And also, what will happen and what kind of complications can a patient have if they are not treated quick and properly?
Good. Stroke is a real not neurological emergency, medical emergency. It's a medical emergency. Why? Because just like myocardial infarction, how is heart attack a medical emergency? Same analogy, same way. If you don't treat a stroke, what happens in myocardial infarction? If you don't treat it properly, the person will die. They will develop ventricular fibrillation, ventricular tachycardia, CCF, or you can die. Suppose it's a massive infarction. In stroke, persons can die similarly if you don't treat them properly. That is one thing. The cause of death in stroke is so many. Because the vital, suppose the brainstem, the blood vessel going to your brainstem is blocked, basilar artery thrombosis. You can die instantly. Suppose the massive occlusion of the terminal ICA or the proximal trunk of the MCA, you get more than 1/3 of the MCA territory infarcted. You call it a malignant MCA infarction. Massive cerebral edema, person will cone and die. So that is one side. There is sudden death can happen in stroke because of these reasons. And other than that, more equally important, I won't say more, equally important is stroke not only produces mortality, it produces severe morbidity. That is the difference between MI and stroke. In MI, either the patient dies or he recovers. Whereas here, if you don't treat properly, the patient might survive, but with significant residual deficit. That is, the person will have complete hemiplegia. He will not be able to speak. He will not be able to move the hand. He will not be able to walk. What happens then? He may be the breadwinner for the family. And that person is now bedridden. So you can imagine what will be the economic burden on the family, what will be the emotional burden on the family, So he becomes a lifelong, the life becomes totally miserable, not only for himself, for others also, in the family. So so we have what is called as a MRS, is modified ranking stroke scale, which is a 0 to 6 point system. Whereas a person with an MRS 6 is a person who is dead after stroke. MRS 5 is bedridden. He needs assistance for all activities, even feeding. MRS 4 and 3 are moderately disabled. One is moderately severe. Disabled is MRS 4 and moderately disabled is MRS 3. MRS 0, 1 and 2. 0 is totally normal. 1, patient does not have much motor deficit, but he feels I'm not able to do everything what I've been able to do before. A person with a modified ranking scale score 2 will be able to do most of the activities, but for some, he may need some assistance. He may not be able to do as much as he was able to do. So because of this, because of the morbidity which a person will have, it is important that this disease is treated immediately as an emergency. And if you don't treat them, you can likely to have a person who is really morbid. And what was the second part of the question? Can I know? Question had two parts. This is the first part. What is the second part?
What will happen if they are not treated properly and if they are not treated quick?
Yeah, that both I have told. Okay.
So thank you, sir. Now I understand why they called it a medical emergency.
Yeah.
Okay. So, so how do you diagnose a patient with stroke, and what are the investigation modalities you order in a patient with stroke?
Fine. So I told you clinically, the diagnosis of stroke should be clinical. It has to be clinical. I can tell you, as medical students, you should know how to clinically diagnose a stroke. As I told you, when somebody comes to you with a facial deviation, slurring of the speech, he has got a weakness of one limb, or either the upper limb or the lower limb, sudden onset, you have to diagnose stroke. Stroke will be the diagnosis. This is stroke, and especially this has happened suddenly. I was having a breakfast in the morning. Suddenly, my face deviated. I have a weakness of the hand. I have a weakness with it. I was not able to talk properly. This is a stroke. Now, once you diagnose stroke, you have to confirm it by imaging modalities. Imaging modality. You do a scan. You do a CT scan, computerized tomographic scan, which will tell you as soon as a stroke happens. Why we do a scan is because I told you initially there are two reasons for stroke. One is an ischemia, other is a hemorrhage. In the initial part of the acute ischemic stroke, CT scan will be normal. You won't find anything much. But you can diagnose a hemorrhagic stroke. You can diagnose a hemorrhage. You can exclude a hemorrhagic stroke. Even though I said CT scan is normal, what I meant is there won't be much of infarction in the initial period. It takes time. Do the scan, second day you will see the infarction if you're not treated properly. But there are a few signs which you should look for even in the initial part. As medical students, since this forum is there, I have to tell you that. You look for what is called as a hyperdense MCA sign. You know, what is happening in a stroke is your middle cerebral artery in the anterior circulation is getting blocked. You can see the thrombus inside the, sometimes, not often, but you have to look for that. Or you have to look for a hyperdense basilar artery sign. Or you look for what is called as a MCA dot sign. These are all the finer points which I'm telling you, which a good neurologist should look for, a good clinician should look for, and find out, okay, then you know you're dealing with a stroke as a CT scan. Then, not only the CT scan, now we do what is called as an MRI. MRI, in not the routine MRI which we are looking for. We look for what is called diffusion weighted MRI. what you call as a, you see diffusion weighted imaging changes in the MRI, which is highly suggestive of acute stroke. Changes in the MRI diffusion weighted image happens much earlier than what happens in a CT scan. Another imaging modality is what is called CT perfusion. CT perfusion, the facilities are there, it will tell us, and CT angio, which will tell us the site of occlusion and the degree of ischemic penumbra. Then, other than this, you do vascular studies in the form of carotid Doppler studies. Carotid Doppler will tell you whether there is what is the status of the carotid arteries bilaterally and the vertebral arteries extracranial, whether there is an occlusion, whether there is a what you call the carotid bulb is the commonest site where you see the plaque in the extracranial carotid arteries. And if the facilities are available, we do what is called as a transcranial Doppler. Transcranial Doppler is a little more advanced thing where you can visualize the real-time blood flow to the brain. And we can find out whether the middle cerebral arteries, your ACA, your vertebrobasilar system flow is good, whether there is an occlusion, whether there is a stenosis, whether there is a dissection, all those things can be. And simultaneously, you can look for microemboli signals which is traveling from the heart. So these are the imaging modalities. Then that doesn't mean you should not do the baseline blood investigation. Very, very important. Any acute stroke, you have to do a blood sugar, cholesterol, renal parameters, liver parameters, your prothrombin time, then platelet count. All those things has to be done to find out what is the basic hemoglobin level. Sometimes the stroke may be caused due to increased hemoglobin, polycythemia. Unless and until you do a hematocrit, you will not pick it up. Then, if you're really interested, you can go in for the coagulation fibrinogen level. And of course, in special situations of stroke, you look at your coagulation, the various clotting factors like protein C, protein S, antithrombin 3. All these things we do in selected cases when we don't find a routine cause of the stroke by all the other imaging modalities. So these are the investigations which you do to find out, to diagnose stroke.
Thank you, sir. You clearly explained it all. So what is the treatment protocol, management protocol or treatment protocol in the management of stroke? And are there any surgical options? And when do you prefer to do surgery?
Yeah, nowadays, this death from stroke has become much less. If you treat the stroke properly in the initial period, which is called as a golden period of management, is the first 3 to 4.5 hours. As medical students, that is what you should practice. When you come across a stroke, don't delay in the proper referral. Actually, in the proper hands, first 3 to 4.5 hours, you will get an acute ischemic stroke. Now you have got wonderful medicines, what is called as thrombolytic agents, which is tissue plasminogen activator, recombinant tissue plasminogen activator, which dissolves the clot. Previously, there was only an RTPA which was available from 1998. 96, it got approved, US FDA, US Food and Drug Administration. But that was little expensive actually. So it was not possible for us to treat every patient with recombinant tissue plasminogen activator because the cost was a little on the higher side. Only a few people could afford that. So this prompted us to develop a medicine indigenously in India, thrombolytic agent, which is useful for treating acute stroke, which is affordable. And I was one of the principal investigators for that. And we developed a drug called tenecteplase for the management of stroke. It is also a plasminogen activator, but which is different from that, which we developed indigenously in India. The problem with RTPA, the first one was which has to be given as a bolus over 1 hour. Whereas what we have developed, we can just give it as a bolus. So within no time, within 1 minute, you are delivering the drug. And the cost is almost 1/3 of the first drug. So we were responsible for that. And we were responsible for developing the drug. And India, as far as acute stroke treatment is concerned, is really in the forefront, because we were the first country to approve this after the phase 3 trial which we did, and we got the DCG approval. And subsequently, you know, this drug is now used by several other countries. So this is one thing which we can be really proud of, because we have developed this actually. So this is a drug which is extremely useful in acute stroke treatment, and this is a thrombolytic agent. So and majority of the strokes, ischemic strokes, can be cured with that. And suppose even after giving this drug, suppose the clot is not lysed, then what we do, we go in for intervention, neuro intervention. We put in a catheter through your femoral artery, go up the carotid, go to the middle cerebral artery, you remove the clot. This is called thrombectomy. This is done not opening the brain. This is done as through the endovascular approach. So the patient is out of the thing within 1 hour, 2 hours. If the person was having a weakness of limbs, speech problem, he starts moving the hand and the limb. So this is another great development which has happened now. Neurointervention wise, we remove the clot. There are so many devices to do that, which is not part of this discussion. Okay, and we do that when it is needed, when the thrombolytic agent doesn't work. Now, other part of the story is the surgery. Surgery is not the usual thing in stroke. It's the last thing which is done. And when do you do surgery? When do you ask the neurosurgeon to intervene? In those cases, when there is a malignant MCA infarction, the MCA is infarcted so much, huge cerebral edema, then you do what is called as a craniectomy. That is, you remove a flap of the bone, allow the brain to expand, so the cerebral edema comes down. Suppose there is a cerebellar infarction, infarcts the posterior fossa. So the IC intracranial pressure rises quickly, or hemorrhage in the cerebellum. You remove a flap of the occipital bone and you allow the brain to expand. So you prevent the ICP from causing a coning. So those are the circumstances when we do surgery. Otherwise, stroke treatment is not generally surgical. Don't go with that to your brain. It is medical and endovascular. Okay.
Okay, so now I understand what happens as a management or treatment for a stroke patient. So now we are in the end of the session, and I'm a medical student. So if I witness a patient, or how do I find that a person is undergoing stroke, and what do I do as a first aid management to help them? Something which I can do.
Fine. You see, now from our discussion, you know how to diagnose a stroke. So that is fundamental. Coming to a diagnosis of stroke is important. That is when somebody is developing a slurring of the speech or weakness of one side of the body, and you know the patient has suffered a stroke, and that is happening right in front of your eyes, or it is, if you know that this has happened recently, what you should do is suddenly shift the patient to a facility where stroke treatment is available. Stroke treatment is available. That's very, very important. Don't shift the patient to a facility where the stroke thrombolysis is not available, because you know the first 3 to 4.5 hour period is called as a golden period in the management of stroke. If you don't thrombolyze the patient during that period of time, subsequently, even if you do a thrombolysis, you may not be successful in lysing the clot, but you will be producing more hemorrhage in the brain. That could be devastating for the patient. So straight away shift to a patient where thrombolytic facility is there, stroke facility is there, because you know nowadays it is not like routine ICUs. We don't treat stroke. We have a stroke unit. Dedicated stroke unit is there where we treat stroke. That's different from the routine ICU, because where the nurses are trained, because our blood pressure targets are different from the targets which are routine ICU, where a heart attack is treated, where their initial protocol is to lower the blood pressure. But here we try to maintain the blood pressure to a level so that, you know, what happens in stroke is a cerebral autoregulation is disrupted. Cerebral autoregulation. That is very, very important. Cerebral autoregulation is a big thing, big chapter. How in stroke that is disrupted. So what happens to the cerebral blood flow? It is totally dependent on the mean arterial blood pressure. So if you lower the blood pressure, acutely after stroke, you will cause an extension of the infarction. That is what we see. Inadvertent reduction of blood pressure after an acute ischemic stroke will cause an extension of the infarction. So don't straight away, as the patient with acute stroke comes to you, don't put a sublingual nifedipine into the mouth, which I see happening quite often. That will cause an extension of the infarction. So that is why I said stroke ICU is different. The management targets of blood pressure are different. So once the patient is the stroke ICU, the chances of survival of the patient is much high. But routinely I see the patient with blood pressure 170 by 100 comes to your ICU, you are given a sublingual nifedipine to make it 120 by 80. Now, a patient who came walking with a mild stroke, you make them totally paralyzed. So don't do that. Don't do that. So the treatment protocol of stroke is different from treatment protocol of myocardial infarction, and management of blood pressure is totally different. So that is why we want the patients with stroke not to be admitted in the general medical ICU, where the treatment protocol is different. So they have to be admitted in a stroke center, stroke unit, where thrombolytic facility is available, and that will cause better recovery of the patient. So straight away shift the patient. Once you diagnose, so immediately the scan is done and you start your management protocol. Stroke is a real emergency. You have to, whatever you have to do within the first 4.5 hours or 6 hours. But now with when neurointervention facility is available now, you can even you can even treat up to 12 hours. Okay.
So, sir, we had this doubt session and we have this doubt from the students. So they have asked that usually stroke patient, they have this weakness or paralysis. Do this paralysis or weakness, can this be reversed?
Yeah, that is exactly what I told. When a patient comes to you with a total weakness of your face or the arm or the lower limb, if you treat them properly, if you are able to, this weakness is happening due to an acute occlusion of the blood circulation of the vessel supplying the brain. If you are able to lyse that clot, if you are able to re-establish the circulation, if you are able to shift the penumbra from 10 to 20 ml per 100 gram per minute to your normal blood flow, 30 to 40 or 50 ml per 100 gram per minute, your paralysis is totally reversed. So you can reverse it, provided you treat them properly.
So people, please, who have doubts, please post them in the chat section. Section.
Yeah, the first question, the chances of reperfusion injury, is it not? Am I audible?
Yes, sir. Yes, sir. You're audible.
Yeah, one question came on what are the chances of reperfusion injury. Good question. Very good. Actually, you have to be very careful about reperfusion injury. You have to be, we are very watchful about that. You're very watchful. See, once the thrombolysis happens, once the thrombolysis has happened, once we open the vessel, we lower the blood pressure. Not before that. That prevents a reperfusion injury. Then another thing which we do is we have, that is what I mentioned about transcranial Doppler initially. The by transcranial Doppler, we know what is the circulation which is happening, how much hyperperfusion is happening. Based on that, we control the blood pressure. What is the other question?
So someone has that, can the concept and practice of idea of the golden hour be feasible in all cases, especially when a pregnant woman has stroke?
Oh, can you repeat the question?
The concept and practice of golden hour, which you said, is that feasible in all cases, especially when a pregnant woman has stroke?
No, no. See, the concept of golden hour is there, whether it is pregnancy or not. Pregnancy or not. The concept of golden hour will hold good. Because unless and until you lyse the clot, whether the person is pregnant or not pregnant, the person will not recover. Person will have constant deficit, focal neurological deficit. Person will be monoplegic or hemiplegic, which we doesn't want. So there the priority is to lyse the clot. Priority is to lyse the clot. So what will happen, So that is being practiced everywhere. So we always try to dissolve the clot within the golden hour. Of course, the specific question of a pregnant lady getting an acute stroke. One thing I want to tell you. In pregnancy, the incidence of the arterial strokes are much less. It is the venous strokes which come across. We come across more of venous strokes in pregnancy. There, we don't have to thrombolize usually. They usually respond to heparin. So we can give heparin and thrombolize them. That is safe.
Okay, sir. So there is this another question, sir. Is there any way where on spot when the person collapses and it can be diagnosed as stroke?
Okay. So it's a good question, but maybe at your level, I don't think it will, because it is unless and until there you may need a neurological help. We look for the specific focal signs. If you can look for focal signs, that is, even if it's unconscious patient, you give severe painful stimuli. You pinch the supraorbital area. You give a supraorbital compression, chest compression. You can see one side moving, the other side is not moving. That is the unilaterality, which gives you a clue you are dealing with an acute ischemic stroke. So that is one thing which you can always rely on.
Okay, thank you so much, sir. And sir, can you tell us any interesting case that you have seen till now in your clinic or in...
Oh, lots and lots actually. We daily come across something or the other which is interesting. I'll tell you, since you asked last week, a person came to us with intense headache, vomiting. So headache and vomiting. So the person, what happens is normally you do a CT scan. That CT scan was normal, absolutely normal CT scan. But the person is having one of the worst headaches of his life. So 37-year-old man. 37-year-old man. He was a smoker, heavy smoker. And he was in the habit of taking substance abuse. We did an MRI because we know, once we suspect things, we take straight away go to our thinking process. We were just thinking in terms of a cerebral venous stroke in this patient. Venous stroke, because there is no hemiplegia, no focal deficit. Headache, vomiting, features of raised intracranial pressure. When somebody has got features of raised intracranial pressure, we should suspect a venous stroke, because it is the veins which drain the brain. And only when the drainage is affected, your brain pressure goes up. We did what is called as an MR venogram. MR venogram is a sequence of MRI where you selectively see the venous system of the brain. And as expected, what was happening was all his venous sinuses, as you have learned your anatomy, there are so many sinuses in the brain. Superficial sinuses, deep venous sinuses. Almost all the sinuses were occluded. Almost, excepting one transverse sinus. So we knew what we were dealing with. One of the most severe forms of cerebral venous thrombosis. So what we did was we gave the patient heparin, anticoagulated the patient. Within 3 to 4 days, his headache came down, his features of raised intracranial, which we were monitoring frequently, the intracranial pressure. The ICP came down, patient became much better, and with 10 days he had to be in the 4 5 days he was in the ICU. Subsequently, we shifted him to the room. After 10 days, when we were discharging, he was symptom free. Such patients, we anticoagulate them because he had actually um, what he call as his autoimmune profile was positive. So he will be anticoagulating the patient for quite some time with the non-vitamin K Orlan NOAC. We have put him on NOAC. So we come across this stroke is such a big challenge. Every week we'll have some interesting problem. Okay.
Yes, sir. So thank you so much for sharing this experience with us, sir, and also for your time. I really enjoyed this session. I learned a lot about stroke. I have heard about this, but all these information you gave about the investigation modalities and what to do as a medical student, it helped me a lot. And thank you so much for your time. We are, time is like you have given us your time and also your knowledge. So please keep doing this. Please keep helping us students to learn more and to be a better doctor. Thank you so much, sir. Thank you.
Okay. All the best for all of you.
Thank you, sir. Thank you so much.
Okay.
Thank you for so much.
We'd like to